Afternoon, everyone. We'll start in a minute, but just a few more people who are joining. Deep, you're on mute.
Okay, all good.
Great. Excellent. Right. I think we should start now. Okay. Nearly there. Good morning, Canada and US. Good afternoon to UK and Africa, and good evening to people joining from India. Welcome to Umesh Shah Presents Sunday Life and Learn Talks. Today's speaker is Dr. Deepak Sirur, who will be talking about addictive behaviors, how to recognize and manage them. Dr. Deepak Sirur qualified in 1997 from the University of Manchester. After doing his pre-registration year, he has been working in psychiatry and has obtained his membership for the Royal College of Psychiatrists, and his area of specialism is substance misuse psychiatry. Since 2007, he has been working as a consultant addiction psychiatrist in North Derbyshire. His areas of clinical interest include management of opioid and other substance dependence and dual diagnosis of coexisting mental health and substance misuse. Without taking more time, Deep, over to you.
Thank you. And thank you for having me for today. It's a pleasure to be invited, and thanks everyone for taking time on Sunday to listen to what I have to say. So I'm going to talk, as Umesh has said, about addictive behaviors and how to manage and recognize them. So it's a big topic. So you won't come out of here knowing anything and everything there is to know about the minutiae of substance misuse. I go on conferences every year and we just touch on half of it or a quarter of it even in a week. So, but what I'm aiming to do through this presentation is to provide a definition of addiction, to highlight the scale of the problem and risks. The figures are based around the UK for those who are tuning in from outside of the area. A little bit about the science, and some hints and tips for people to either recognize any problems potentially amongst themselves or if they're there with family and friends, and a little bit about what the treatment you could be expecting to access and receive as part of the overall package if you have access to substance misuse services. Again, these will vary from country to country, but will probably be based around broadly similar principles depending on how accessible services are or whether you're accessing public or private health systems in different parts of the world. Now, it's such a big area, addictions, but my particular area is more around drugs and alcohol. So I put a bit more of a focus on alcohol because I think it's quite topical, and although drugs tends to make much more of the headlines in terms of mental health and harms, it is actually a bit more. Alcohol is a much bigger problem within the country and across the world, actually. So I'll put a bit of emphasis on there. But the broad principles of managing addictions, spotting them, recognizing, are pretty much similar. There are slight differences depending on what the substance of choice is, but the recognition, the definitions, etc., aren't too dissimilar. So I'll move on then. So I think the first thing to clarify or to have a think about is differentiating between what is an addiction versus what is doing a lot of something. So, for example, I've just been watching the Olympics and stuff this morning. There are a lot of people who do an awful lot of running, jumping, whatever, spend an awful lot of time obsessing about their weight, spending massive amounts of time in the gym, running 3, 4, 5 times what they actually need to do to perform. Now, is that an addiction, or is that something that they do a lot of? Likewise with eating, social media, gaming, keeping your house tidy, and there are a lot of people who are kind of obsessed with work. So, but there's so what we need to be thinking about is what's the difference? But when would we call something an addiction, and when is it something that we either enjoy doing a lot of or we end up doing a lot of? So I've based my definitions on the World Health Organization ICD-10. So this is a system which is worldwide, set up by the World Health Organization, where there's a consensus of how we reach different diagnoses. If you're in the US, the diagnostic manual that is used for these kind of disorders is likely to be the DSM-4, which will have slightly different criteria, but broadly, they won't be too dissimilar. So to meet the criteria for a diagnosis of dependence, which is the term we tend to use, addictions are kind of fairly loose term, but we tend to talk in psychiatric terms about specific dependence. Now, that could be the physical or it could be psychological. And to meet the criteria, you need to be demonstrating 3 or more of the following things for usually about in the previous year. So the first one being a strong desire or sense of compulsion to take a substance or do an activity. Difficulties in controlling behaviors in terms of their onsets and levels of use. Physiological withdrawal states when use has stopped or been reduced. Now, this is largely based around certain substances which have physical addiction. And we're talking predominantly drugs like heroin. We're talking about drugs like benzodiazepines and alcohol, all of which have a recognized physical withdrawal symptoms. Increasingly, we are seeing withdrawal symptoms in other substances which we hadn't previously recognized. So that area is potentially growing, but currently we would regard there's a limited number of substances where we would work on the assumption there's an active physical dependence. The other thing that's broadening to a degree is how one would define a physiological withdrawal state. So ordinarily that would have been based on the direct reduction or cessation of a substance. Increasingly, we're able to look inside people's brains whilst they're alive and do all sorts of fancy scans. And we're able to identify physiological changes in the brain based on activities that people are doing or stop doing. So there is increasingly an argument, should we be thinking of a withdrawal state purely in terms of substances or alcohol, or should we be thinking about the physiological state in the context of stopping doing something and any brain changes that have happened? We've got to remember in psychiatry that up until not too long ago, I think in the 90s, probably a little bit earlier, maybe the late 80s, was the only time where more fancy scanning became available in terms of what was happening within the brain. Prior to that, if you wanted to look inside the brain, you'd have to wait till someone had passed away, or you would get a wonderful X-ray of the skull, but it wouldn't tell you what was going on underneath. So there's been some massive advances in imaging technologies which have helped quite markedly in giving us an understanding of what's actually going on inside our brain now. So I thought I'd just quickly add that in. One of the things then, these are further things which we need to be thinking about in terms of the definition. So one is evidence of tolerance. So increased doses or amounts of activity are required to achieve the original produced by lower amounts. So for example, people who drink, who may well have got an effect off that drink for to give them what they wanted, the amount they need to drink to get exactly the same effect would be needed to give that kind of effect. And that's why and how people escalate in terms of what their behaviors are. And if we're looking at other behaviors, which may be things like gambling, the stake of what people have to bet to do it, the speed of return on reward, so increased use of fixed odd betting machines where you can gamble very quickly, or the growth of internet gambling is you can see those kind of things, and classically with cigarettes as well. So the other thing which is of relevance in terms of when we're looking at seeing something as an actual problematic dependence is a progressive neglect and alternative pleasures or interests because of a substance or another activity, and increased amount of time necessary to obtain or take the substance or recover from its effects. Now, that's quite an important thing. E and F, which is persisting despite clear evidence of overtly harmful consequences, such as harm to physical health through the liver, for example, for drinking, other health impacts if people are intravenous drug taking, and or depressive mood states or interactions of mood because of their substance or behavioral activity. So it's very clear that it needs to be a longer term thing, which has happened. There needs to be a clear consequence to stopping doing that activity. It needs to start being the kind of focus of what somebody's doing, and there needs to be a component of harm. So if we look at, for example, the athletes who do a lot of exercise, they may like doing exercise, they may dislike it, it might be part of the job. I didn't like reading loads and loads of textbooks, but in my early stage of the career, I had to read an awful lot of things which perhaps weren't my cup of tea because there was a reason to do it. It was to get a medical degree. But I'd never say I was addicted to reading. It was a means to an end, which luckily worked out for me. But the thing is, we need to think about is that it's something which is to do with harms. It's something to do with it becomes the full focus. People use the terms like on this slide of knowing that it's a harmful activity, for example, the narrowing of people's personal repertoire. So that means that the whole life becomes focused on what you're doing. That's the only salient activity in people's life. If you are a drinker, for example, you may start drinking socially. You may have a range of drinks that you would have. You may drink differently in different situations, but as dependence gets stronger and stronger and takes more of a control of your life, pretty much your whole life is geared around the need to maintain that physical dependence and pay for your addiction. So, and what you drink may well vary. So it's not uncommon for drinkers ultimately to graduate onto a hard spirit. Usually vodka's quite easy to get hold of and is a clear spirit of a high concentration, quite concealable. So it's not uncommon then that becomes the main drink, and that's the only thing people drink when they're in active dependence. If they can get hold of it, obviously people will take what they can if their main tipple isn't available. So it's also an essential characteristic of the dependence syndrome that either the behavior or a desire to do it should be present. So it's not something which people do just because they have to. They want to do it. They're driven to do it. And that was manifest by people's inability to stop doing something despite other priorities coming along. So that's a key thing to also think about. And also the subjective awareness of compulsion when people try to stop it. So this is a situation where if people are trying to stop, they'll look at other mechanisms to get hold of the substance if they've told people they're trying to stop, but they'll be seeking out the substance where they can, or of hidden stashes somewhere, things like that. Okay, so this is a fairly basic but helpful understanding of the brain to think about how addiction fits in and where it works, because I think that one of the key messages of today is to think of it as a physiological process and start moving away from the I suppose the old narrative that anyone who takes too much of a substance is taking part in a bad behavior, which they know they shouldn't do. And they just need to stop doing it, and they're being a bit silly because it's obvious to them and everyone else that it's not helpful for their life. Now, that's all true, but also most people who are in active dependence or are trying to manage their difficulties will also know that themselves, which is why the response often to those kind of criticisms, if you happen to know someone with a substance problem, is that they kind of get very angry. They usually get angry because you're telling them something they already know themselves. They recognize all the harms, as it said in the previous slide, but it's the how to stop bit which is a problem. And increasingly, as I mentioned, we're getting a bit more of a broader understanding of what's going on behind that skull to give us an idea of what's going on. So this isn't a full physiological model of what goes on, but in essence, you've got some core parts of the brain which are involved. So the hippocampus area, there's the kind of primitive brain, which is this area here. This is that's the I think that's the amygdala, and this is the hippocampus, and these are the prefrontal lobes or the frontal lobes. So what you tend to see is when your brain is functioning normally and usually not under any stress, your impulses tend to be driven from this area of the brain and based on this area of learning. That's your memory bank of what works, what's good, and what you know. This kind of modulates those thoughts and derives a kind of impulse, which is kind of your, if people say your gut feeling, probably comes from here. Now, what normally happens is before you do anything with it, those impulses and signals go into this area, which is responsible for what we call our executive function. So that's our planning, are thinking things through, is it right or is it wrong to do things? And most of us may well at times have had thoughts where they've thought, actually, in this circumstance, probably not the best thing to do. That would be the work of the prefrontal cortex. So one of the things then, what happens in addictions is there's some disruption in that process between how the amygdala and the prefrontal cortex talk to each other through neural pathways. We don't really know yet whether that's cause and effect. Has that happened because people have got addiction problems and the brain develops as a result of that? But what we certainly see is there are changes in compared to normal people who don't have addiction problems in terms of weighing up the rights and wrongs of decisions. So commonly you'll see with people with alcohol problems that when they're in a situation, even if they've had really bad problems with a substance, they won't actually focus on the negatives and the harms associated with it. The pathways and the signals from their brain that they're getting from their brain are telling them, yes, those risks are there. However, the good bits of it are far better. And it's almost like those thoughts go on a high-speed motorway at 70 miles an hour, and the pathways which will tell you that this is rubbish and you shouldn't do it because the last time you did it, you turned yellow and ended up in hospital. That kind of doesn't work so well. And that kind of then is traveling, I don't know, on a country back lane on a cycle. So by the time it gets there, it's too late. The thoughts to do something which aren't the best things to do have already happened. The other thing you see in drugs is there's a disconnect with certain substances between these processes. So when people have alcohol, and if anyone on this call drinks, they will probably be aware that once you've had a certain amount, the time between thinking about doing something and actually doing something seems to be reduced, and you do things generally with a lot more thought at the time that isn't absolutely the right thing to do. And if you've drunk a little bit too much in a social situation, you may well have had circumstances where at the time it seemed completely reasonable. And then when you woke up the next morning and realized you'd caused a bit of social upset or worse, then you realize that perhaps you hadn't thought it through. So those functions get disturbed with particular substances and intoxication. Benzodiazepines, so diazepam and various sleeping tablets do that kind of stuff, as do stimulants, so cocaine, amphetamine, and other drugs like that. Okay, so that's a little bit on the science, but the other thing, as I've touched on previously, is we've got to reconcile or think about the difference between how much of this is an active disease where there's a physical or physiological process going on in the brain which makes people vulnerable, and how much of it is a learnt behavior to deal with stress, or is in effect a bad habit which keeps continuing. What we have found is we've learned more about psychiatry in terms of how disease processes work. We've always stuck to what we call a biopsychosocial model, which means that most of the illnesses that we study, there'll be an element of biological stuff going on that may be inherited, that may be structural in terms of how your brain works or functions. There'll be a psychological element, which is how your thinking patterns have developed, and there'll be social elements of any illness, which will be what your social circumstances is. So, for example, you can have someone who's got a lot of predisposition for something biologically. For example, they may have all the genes which suggest that they may be a high-end drinker, but if their life circumstances are go in a particular way, that may not get activated. Or maybe if they're prone to impulsive or dependence or obsessional type behaviors, it might be diverted into something much more positive, like an athlete who's winning golds at an Olympics, rather than somebody who's getting off their face on crack cocaine, which is generally less fulfilling, and the outcomes are much worse. So the evidence we have is that most diseases, and I think which we study in psychiatry, will have a combination of all those three factors, and there are very few, if any, where they've identified specific genes which say, if you've got this, you're going to get this disease. I think what seems to be happening, if there's anyone who's psychiatric on this call, they may know a little bit more about this side of it, that we have a bit more kind of understanding that things are going on which may predispose you to getting a mental illness or a maladaptive behavior pattern. Your psychological circumstances and your early upbringing may well lead you down a particular route, and then your ongoing social circumstances may then shape, if you're destined to get a mental illness, how that illness is going to look. So in that sense, we're still trying to work out how and why, if those things are there, does it turn into an addiction? And also not forgetting that addiction is also, you can have other illnesses running concurrently with that. Okay, so a little bit more of a focus on alcohol then. As I said, these figures are based on the UK. It's most commonly taken substance abuse and dependence. It probably also is by and large around the world. In terms of the NHS, I think, and I'm happy to be corrected, we're roughly spend about 150 billion on the NHS, and estimates suggest that up to 3.5 to 5 billion per year is spent on as a direct result of alcohol. So that's a specific NHS spend. That's looking at all the costs associated with treating people, providing services, bed occupancy, ambulances, all these kind of things. And that puts it up in the top 3 problems with respect to spending in the health service. There's a broader societal cost to alcohol in terms of productivity, so lost days from work. If people remember when there are big sporting events or celebrations, turn up at work the next day might be a little bit reduced, or people might be a little bit sluggish because they're nursing a bit of a hangover, or they'll be taking days off. That can cause a financial cost. Also, costs of managing the social harms of alcohol. So in terms of housing, in terms of the criminality, criminal damage, all these kind of things cost, and it's estimated the cost of the economy is up to 2.7% of the GDP of the UK, which is quite a big percentage. I don't know what the specific GDP of the UK is at the moment because it fluctuates a lot, but it's a ballpark. That's how much it costs the economy, and that is quite a lot more than the GDP associated with the hospitality industry and alcohol, and any tax and revenues that alcohol brings in. So there are certain fora where they perpetuate a myth that alcohol pays for itself. It actually doesn't. There's a net cost to society, and it's not neutral. Prior to pandemic, year-on-year increase in consumption harm was already there. What we did find during the pandemic, though, is things which were already a problem in all fields actually were accelerated. So these pre-pandemic figures showed that 1 in 10 hospital admissions were likely to be related to alcohol in some way, shape, or form. So that was either physical stuff, harmful use, intoxication, accidents, potentially harm to other people as a result of alcohol. 20% of those were thought to be harmful drinkers, and 10% likely to be drinking dependency levels. Now, what made a bit of news recently back in July was the specific effect of the pandemic on alcohol consumption. In our services, we were seeing a gradual increase, and we predicted to a degree that there would be a high level of alcohol consumption. Now that was seen live, if you like, in terms of what we were dealing with on the ground. Recent reports from public health have evidenced that now, and it did have quite a significant effect on particularly the use of alcohol. The report by the public health was published in July and is obtainable if you're more interested on the website. It was quite well reported in the newspapers also, and they showed a significant increase, up 21% of the previous year, of alcohol-related liver admissions. And they also found that up to 58% of people increased their drinking to higher levels than pre-pandemic. There's a great amount of harms associated with people who are already drinking harmfully or dependently. And there was a 20% increase on the year of alcohol-specific deaths, and a 10.8% increase on alcohol-related deaths linked to mental illness. So one of the problems one has with alcohol and mental health is a lot of people with mental health problems will self-medicate. It's estimated that potentially up to 25%, maybe more, will have a concurrent problem with the substance, largely with alcohol. And that will be used to take the edge off their mental health symptoms. Unfortunately, with alcohol, it also has a disinhibitory effect. So if people are feeling particularly rough and their mood is in a bad place, things which they may think twice about, they're more likely to do. So it's often implicated in fatal overdoses, in extreme impulsive acts of self-harm and death. So, for example, deaths on the road, intentional deaths on the road, jumpings off bridges, hangings, things like that, which if one goes wrong, there's very little chance that that you're going to be saved. So alcohol and other drugs that tend to be linked a bit to those kind of things. Now, interestingly, with the alcohol, we've got a lot of myth busting that we need to do. There are various vested interests who have it's in their interests for us to continue to use legal things which cause us problem, and I'm including in that food and sugar. I'm including in that gambling. I'm including in that alcohol, and I am including in that also, but less so now, tobacco. So whenever people have got money to make from things, they often have a powerful lobby group which will provide other information which may weaken the scientific evidence, but it'll be presented in a very good way. So one of the things I noticed about the report that came out about in the papers is they seem to imply that although there were problems with drinking, those was restricted to people who already had significant drink problems anyway, aka the vast majority of the population were absolutely fine and it did nothing. Now, technically the report did say that, but what they also said in the small print was that was if you look at all the research. If you look specifically at the high quality research, then you see a different picture. And the picture you see in that is most people who drank were drinking to higher levels than they were before. So people who weren't drinking hazardously would be starting to drink hazardously. People who were drinking hazardously are now drinking harmfully, and people who were broadly drinking harmfully were developing significant physical and mental health consequences of that. There was a very specific cliff edge from when lockdown happened, and the thing of concern, which we need to watch from a treatment point of view, is as lockdown restrictions have eased, we're not seeing a consummate reduction of people going back to their baseline levels pre-pandemic. So something has happened, people are drinking more, the harms are increasing associated with the alcohol, and that doesn't seem to be getting any better as we loosen restrictions. So there's a bit of concern that we're storing up big problems, which we'll have to deal with in the future. It is the leading cause of death in men between 35 and 49, not alcohol on its own, but in acts of self-poisoning, usually in combination with other sedatives. And these are specifically accidental deaths, not so much suicide related or people intentionally taking their own life. Now, that's overtaken what used to be the leading cause, which would have been cardiac related problems. So this is a big problem. Suicide and undetermined self-poisoning is actually the highest cause of death in young males in the country, within that age group, 20 to 34. So this is a huge area which society really needs to get its head around and focus upon. And as I said, alcohol has been quite a significant factor in disinhibitory effects, as have other drugs. So it ties in with this one also. Estimates that 1 in 5 of the UK drink to a harmful level. So that's about that's a good chunk of the population who drink too much. And just in terms of the words, harmful is and hazardous have specific meanings, which I'll come on to in the next slide. So in terms of amounts, we're talking about recommendations which are set by the CMO, the Chief Medical Officer. Now, if I'd have done this slide in this presentation 2 or 3 years ago, I doubt anyone would have known who the Chief Medical Officer was, unless you're well read or you're in the field. I certainly needed to remind myself every now and again. But of course, now everyone knows Chris Whitty, our safe guardian, who did quite a lot of positive work during the pandemic. So one of the key things with alcohol is people say, oh, we don't know what to do because the recommendations always change, which is true. There's been a lot of fluctuation recently, but now I think we've settled on things which we know to be true as we know them at the moment. And that is that there is the myth of alcohol being good for you or safe for you has been roundly gone. You know, there is no safe limit of alcohol. There used to be, certainly in the 90s, there was lots of suggestive research that a small amount of alcohol may actually be good for you. Red wines helping against cardiac disease, or just alcohol in and of itself being a positive thing for your health. Those research articles have largely been debunked. I don't necessarily think they were done with bad intention, but the nature of the research didn't correct for the fact of social determinants of health. So from which I mean, if you're rich, you're likely to live longer and be healthier. And if you're poor, you're likely to have much harder lives and die younger and have much more disease illness as part of your life. Now, what we do know is general increased alcohol consumption tends to live within more affluent circles of society. And that tended to conflate with the research, it was people's social class and the health associated with their affluence, which was much more relevant to why it looked like these guys were getting healthier because of alcohol. So that's not the case. But I'm not planning to be a killjoy. 14 units a week, which is the now recommended limit for both men and women, has not been shown to show significant harms in most people. If it's taken spaced in the week. So the intention isn't to drink your 14 units in one session. That would be called a very big binge. And just to give you an idea, if people are drinkers, of what a binge is, the definition of a binge is not 10 pints of lager on a Friday night. A definition of a binge is actually 6 units, which is the equivalent of 3 pints of normal strength beer, or 6 small glasses of wine for a female, and 8 units, 4 pints for a male. So a lot of people who do drink or have historically drunk fairly healthily, in inverted commas, which isn't healthy, would be a little bit worried that having a 4-pack would count as a binge. But those binges are associated with significant health risks. Hazardous drinking, which a term I've used, is when people drink between 14 and 35 units if they're female, 14 to 50 units if they're a male. And that's a pattern of drinking which is potentially linked to risks or harms. Harmful drinking is where people who are female are drinking more than 35 units and men are drinking more than 50 units. And when we talk about harmful drinking, we're talking about people who their drinking is highly likely to be causing some kind of physical or mental health illness problem, or storing something up, which is going to happen. Just as a reminder, we calculate units with this formula below. So it's the volume of the drink that you're drinking multiplied by the percentage strength of that drink, and then dividing that by 1,000. So that will give you the thing. These days, when we used to talk about units as to, a large glass of wine or a pint, that was based on much weaker concentration drinks and smaller measures. And I'm sure a few of you may well have friends or uncles or fathers who would quite happily say, I'm only drinking 2 bottles of wine, two large wines a night, which is within the recommended limits, but the wine glass was a massive goblet, and in effect 2 large glasses of that was pretty much half to a full bottle. So it's important that we recognize how much we're drinking in terms of volume, what the strength of it is, and think about it in that context. So next slide. Okay, this is a basic screen tool we use where we are, if you think that people may have problems with drink or any substance for that matter, are very basic questions that you can ask to consider whether there are more problems going on. Now, this certainly doesn't tell people whether they've got a problem with the substance or whether they've got a dependence syndrome. It simply helps to identify whether people may need a bit more thought around their drinking, or whether they need more active assessments. When we're working in a clinical setting, we use different screening tools, and then more detailed tools, and then a clinical assessment to come to a diagnosis if needed. But asking people if you ever felt they should cut down on drinking. Have people ever been annoyed when you've been criticized by your drinking? Have you ever felt bad or guilty about the amount that you drink? And have you ever needed a drink first thing in the morning or when you get up to take the edge off a hangover, get rid of nerves, and the ease for an eye opener? So that's kind of what we're dealing with. Now, how do we spot it? Now, I came up with a few things which may be helpful for people to see whether these are behaviors that they may be doing or people that they know might be engaging in. These aren't in any way diagnostic of a problem specifically with substances, but it may suggest that there's a little bit going on, which may need to do. Generally, if someone is having a significant problem, it'll be associated with various behavioral changes. So if you're spotting changes in people and they're not quite how they used to be, it may suggest something is wrong. So if people have regular routines and patterns, if they change, increased time away from home, if particularly with drinkers or drug takers, it gives them an opportunity or advantage to do it. If they're gamblers, they may be spending times at gaming when in the past they used to be at home, or increased time at home and isolated. So again, if they're drinkers, if they're taking drugs, if they've got gambling problems, most of the things which are not so good to do are quite easily accessible on the internet, and alcohol is quite easy to conceal around the house and home. If people get increasingly secretive in terms of what they're doing or irritable when challenged, if there are problems with finances or at work, increasing sick days, often clustering around weekends, an increase in unreliability, someone who used to be really good at being helpful, and you could count on them to do stuff, are not able to be relied on anymore. Avoiding driving. A lot of people who do take substances don't really want to have problems with the law when it comes to driving, or recognize the risk on the road. So if they are finding excuses not to drive to places where perhaps they used to, that might be an indication that they are drinking beyond drink drive limits when they're out and about. Changes to your regular company. No longer interested in regular activities. We touched on in the diagnosis for changing activities which allow the thing to continue. People who didn't routinely used to meet their friends for pubs may start doing that. People may say they're going out for sporting activities, and they may do them, but they're not really going for the sports. They're going to the pub afterwards. A decrease in self-care, that may well be self-evident if people lose interest in maintaining their deportment, or have less time or money. If there are certain substances, they may be smelling. Alcohol is quite easy to smell and is noticeable in odors. Certain drugs, such as cannabis, again have fairly distinctive odor. If you've got a smart nose and you've smelled stuff before, crack also has some odors which are recognizable. So, for example, looking at perfumes, or smoking to cover it up, mouthwashes, various other chewing gum, things like that might suggest those things. Concerns, particularly with alcohol, about abusive or violent behavior. If this is something which is inside someone which they're able to keep under control, the disinhibitory effects of certain drugs like alcohol and stimulants may well lead to an increase in this kind of behavior. Or if people are taking things which make them psychotic, they may be responding to things which they're not actually seeing and aren't really there, and they may be coming across as abusive and violent, but may actually be trying to protect themselves. It's no less scary if you're in that situation, but the context may be different. Promiscuity may be an issue with if you take disinhibiting things. Breakdown of relationship is often a high likelihood if someone has persistent substance problems, because they're not the best people to live with when they're in active addiction, and also they're probably not like the person that you started a relationship with. So that inevitably causes problems, and it could manifest itself in problems at home. One thing which we have to be acutely aware of in situations where there are substances going on is, are there any children around, and how is what's happening impacting on them? Okay, so other behaviors to watch. Are they neglecting elderly parents or relatives? More kind of in the context of our community, I guess, where Asian people do tend to have more broader responsibilities in the context of extended family duties. Or some things which we sometimes see is people who weren't particularly interested in hanging around or supporting older people are suddenly doing that. Now, that's not because they found God or they think it's the right thing to do. What we often find with older people is they may well be on a large amount of prescribed medication, and there may well be money or trinkets going around, or they may be very vulnerable, so that they can potentially be targets for younger people to obtain money or drugs or alcohol. So they may be going around there for a benign reason, and the older person may value the company, but the actual motive is actually to rob, steal, or take the medication. If you're in a house, medication may go missing. If people have a tablet dependence, benzodiazepine and opiates are quite commonly prescribed appropriately, and other strong painkillers sometimes are as well for legitimate conditions. All these substances are quite good at either causing dependence if you're taking them wrongly or abusing them, or, as you saw in one of the earlier slides, if you've got a problem substance which you can't take, they're quite good at seeing you through until you can next get it. So benzodiazepines are a pretty good substitute for alcohol if people aren't in a position to drink, to prevent them getting ill. Other things to think about, subtle behaviors. I remember talking to someone where they felt they covered it up for a good period of time because they moved their stash of alcohol to very accessible places as soon as you enter the house or in the garage. So they'd come in, they'd go home. As soon as they got in, they'd pick up a can of alcohol or a bottle of wine, which had already been opened and in a glass, start drinking. So it would immediately cover up any drinking that had happened outside the house. Okay, so we have some other changes. These are more biopsychosocial. I am don't know if I'm overrunning a bit because I do tend to ramble, but I'll whiz through perhaps the rest of the presentation because I think we're getting the key themes. But mood swings, low mood, periods of being hyperactive. A recent trigger event, did something actively happen which causes problem? One interesting thing that is there in the background and a lot of people who suddenly go into substance misuse is an undisclosed trauma or an abnormal reaction to a normal life event. So if they may have lost a job, they may have been concealing something bad that's happened to them. It's not uncommon in certain people that these things start up when they've been exposed to some form of violence or abuse and are fearful of disclosing it, or they're saying that they've got over it, but in reality they haven't. So not all of it is is stuff that will be obvious for you to see. Changes in bodily appearance and weight, tremors and shakes if you're having problems with these kind of things, or increasing use of emergency medications and medical services. There are also some certain substance specific things, so sedation, withdrawal and seizures, particularly with alcohol, benzodiazepines, sedation and withdrawals, very common in opiates. Mania and psychosis in hallucinogens and stimulant drugs like cocaine, amphetamine, hallucinogens being things like LSD and cannabis. Markers of chronic liver disease if people are heavy drinkers. The DTs, which is when people have acute withdrawal syndromes, is actually a very dangerous thing. So if people are drinking heavily, our advice from a service point of view is very much not to encourage people to stop immediately. We always worry when around dry January how many people are going to end up in hospital because they were drinking dependently, decide to stop, and then end up getting very, very ill, either with acute delirium tremens, which does have, I think, about a 10% fatality rate, so it's very, very serious, or have what is often underdiagnosed, which is an organic brain injury as a result of acute cessation of alcohol. With both of them in the acute phase, this is called a Vernicas Encephalopathy. So this is about people who are very acutely unwell, they're very disorientated, they may have eye problems and problems with their walking, and they present acutely confused. Korsakoff's is more a longer term consequence of heavy drinking as an acquired brain injury, where on the face of it, people may well be fine, but there's been significant disruption to their ability to make new memories and store new memories. So although they may look on the face of it that they know what they're doing, they're very skilled at using historic memories and what we call confabulation. So trying to work out what you're saying and use their own knowledge, memories and resources to try and think about how we can kind of decide to give you the answer that you want to hear, rather than because they don't really understand what's going on. I said I'd focus mostly on alcohol, which I have, but drugs are still a major problem. They are very much linked as a proportion of people who use them to significant numbers of death. I think there was a report the other day about the horrendous rates associated with drug overdose in Scotland. And as I mentioned in the previous slide, certainly we're seeing a lot more people in their 30s, 40s and 50s dying as a result of self-poison, accidental overdose of particularly opiates. Drugs in combination are particularly dangerous. So if people are on a number of sedative medications, it doesn't become 1 + 1 + 1. They all what we call potentiate each other. So it's more to the power 3. So if you're taking opiates on their own, they will have a sedative effect. If you take opiates with alcohol, they may have a significantly bigger effect. If you take those things with benzodiazepines as well, then the overall load, even though each individual component might not be as big, could well be enough to kill people, and that's not uncommon. over-the-counter and prescribed addictions, we touched on that briefly. This is when people are prescribed things originally legitimately from GPs, or they self-medicate with something for normal problems, but then they get stuck on them. Our service doesn't really cater so much for these, but it is a growing problem. GPs are, however, getting much better at preventing it from happening and working with people if they're stuck on substances they don't want to take. Cannabinoids, cannabis, they're well known. And very, very commonly used amongst people. I think probably within my lifetime they'll be legalized. I don't know. There's a different debate whether or not that's a good thing or not, but that's for another time, I guess. Stimulants, amphetamine, cocaine, taken as powder, or crack, which is smoked, again, are all highly problematic drugs, both in terms of the potential effect on people, in terms of their disinhibitory effect and impulse control, but they, particularly in crack, it tends to be much more linked with higher end crime. So the social consequences are significantly harder. What we tend to find when we talk about drugs is you tend to get similar. We sometimes say that alcohol is a slow motion car crash waiting to happen. You're seeing it, it's happening slowly, and you know what's happening. When you talk about drugs, there are much more social related harms because of the nature of them being illegal and putting you into circles where that could be difficult, or difficult to disclose that you've got a problem if you work in a role where taking something illegal might be career limiting. But the problems tend to happen a lot quicker, and it's much more like a high speed car crash. Recreation, self-medication, and dependence. So one of the things I would always challenge people to think about is why they are taking a drug. So we've talked earlier in the slide about when somebody is dependently using. A lot of people recreationally take drugs or alcohol. I was a student in the 90s. I took quite a lot of alcohol. I quite enjoyed it. Every now and again, I did myself a little bit of harm with it, but nothing consequential. And I knew a lot of people who drank like me, and some people who drank more. But when we're talking about recreational use, likewise, I was traveling when I was I grew up, my college years were in the 90s, and for people of that generation, they may well be aware of dance drugs like ecstasy and amphetamine and things like that. It was not uncommon for people to take these things just at the weekend. They had a great time, didn't do themselves any harm. Not that I'm promoting them at all, but then they'd get on with their lives. It was something they did, just like somebody else might go up to Ben Nevis and climb a mountain. They knew what they were doing, they knew what the risks were, and it was recreation. And then when life became more pressured in terms of time and commitments, it all stopped, just like lots of people who drank excessively at university who become model citizens as soon as they start work. That's recreational use. Self-medication is when we're talking about people who are medicating underlying problems. And when we get into the realms of dependence and harmful use, it's rarely people who are recreational takers. Recreational takers tend to see the risks, know the risks, and will moderate it themselves. There'll be loads of people who never touch base with service because they're doing things and they're in control of them. Things may go wrong, they might accidentally get into things, or life may change, and because they've got access to these things and it's part of their behaviors, it might escalate. But there's a very strong difference between someone who, for example, is self-medicating in a bereavement, so they're using the substance as a medication rather than a proper one, versus people who are just taking a drug. And I think, again, I'm continually reinforcing in these talks that we move away from thinking of problematic substance misuse as a bad behavior that people can just stop. It's usually a problem which needs to be looked at and dealt with, but often it's a symptom of something much deeper that's underlying, either in terms of mental health, social problems, or indeed a lot of people I see there's a lot of undisclosed historic trauma. So what can family and friends do? This is the hard bit, because unfortunately, if somebody is in active addiction, all you can do is kind of be there in a non-judgmental way and try and walk the line between being supportive of them but not enabling, because unfortunately, when somebody's in active addictions, they won't care about their family and friends. They won't care about anything. They'll care about drugs, they'll care about alcohol, and what they need to do to manage their dependence. that isn't them. That's not really them. That's what addiction does to people. And if you talk to many people who have recovered, a lot of their shame and guilt is about what they were like when they were in active addiction, because it isn't them. And a number of people, when they get sober or clean, are prone to depression, and some people commit suicide because they're so disappointed at what they've done and how they've harmed other people during that time. So you have to be there to wait and offer interventions at a time is right. We focus on harm reduction, being non-judgmental. High expressed emotions do not work. You won't shout to put somebody into it. Furthermore, if you create an environment where you're completely anti it, if people are very actively addicted, they'll be what we call a dry drunk or a dry user, where whatever's going on underneath is there bottled up and may lead to other risks, or they will just choose to end the relationship to be with enablers, or they will just conceal their behavior. And often the highest risks are where people contain. A lot of people end up in road traffic related problems or traffic related deaths because they're not allowed to drink at home, so they have to find other places where they do it. Likewise with drug use, the worst thing you could do as a heroin addict is take it on your own, because if you pass out, there's no one there to bring you around or call the police. That's not to say condone it, but it's a tricky line, and there may sometimes be a point where enough's enough and you can't have that person in the house. You may have to call the police. But what you shouldn't be doing is paying off drug dealers. And if you know people are wasting money on drugs, when you give it to them, all you're doing by continuing that is enabling them, and probably it'll mean that things will get worse before they'll get better. But these are things which are easy to say rather than to do, and I fully appreciate that. Boundary support versus enabling. Got to be cruel to be kind. And we have to also think in our various communities how much we're doing is based on our own ego and self-protection because of social and community stigma. I was at an event yesterday where, you know, they were tolerating quite horrible things that were going on within a home environment which was secret, rather than and the telling offs were about the person who was getting drunk in public because of the shame they were causing to the family. You know, so this is common in all societies, but there does seem to be a particular issue in some of our cultures. And if the person who you think has a problem is a child or a vulnerable adult, then it is important fairly early on to get support from social services. They won't take children off you. They will largely be there to support you. And likewise with vulnerable adults, there's various things that can be done through court processes and legal protections and safeguards, because often these people fall foul of being manipulated by more able and sinister people. And it's about, we do need to be more proactive in rescuing them from situations. Okay, so principles of treatment, I'll whiz through this. So we've got to look at stages of change. So as I said, it's all sounded very depressing what I said, but the reality is people change. What we can do is be there for them, and when we're seeing opportunities that to reflect on, do they want to make changes, make those available. Prior to that, we focus on harm reduction, but when people use harm reduction elements of our service, part of what we're doing is giving them a gentle nudge about whether they like it, why they're doing it, are they doing it safely, and then people will come to their own minds as to whether actually is it worth doing or not. And then the hope of that is we move to more of a contemplative phase where they recognize there's a problem, they want to do something about it, and then ideally from that an action phase where people take the bull by the horns, realize they've got a problem, and actively engage with services out there to protect them. Assessments are done as standard as part of our service. They focus on the biopsychosocial. So as I spoke about earlier, are there any physical problems? Are there any psychological issues? And what are the social problems? If somebody's got a substance misuse problem, the easiest thing to do is to lock them in a rehab and get them off it. However, if there are problems with their mental health, if there are problems with their general way of functioning, or they never learn the proper skills to function in society, or you're putting them back in exactly the same environment which created them, all you're doing is setting them up to fail. So it's not just a question of stopping, it's having an understanding of why and putting things in place to reduce the risk of coming back. And in the meantime, being cognizant that alcohol and substances is a relapsing remitting condition. So we do need to be realistic that the first time it happens and people sort themselves out, there may well be relapses, and be prepared for that. Family involvement is massive. Involvement with safeguarding process of their children are there. Building recovery capital, which is the posh way of things I was saying about social stuff. If people are more have jobs, have meaningful relationship, meaningful activities, and things to do, they're less likely to lapse back into that kind of lifestyle. Underlying psychological, psychiatric, and trauma. So again, the easiest thing to do for me, if someone's got a psychotic illness who takes a lot of drugs, is to diagnose it, start them on the right medication. And hey presto, when the voices stop and the delusions end, they don't feel the need to take heroin anymore because that's the only reason they were taking it. Psychological, building people's coping mechanisms, and really being aware that often there is underlying unresolved trauma in people who just can't get better. They're making a choice to self-medicate than open up the wounds of rather horrible things which have happened. So we always have to be trauma-informed and sympathetic. If there is any underlying physical causes, we look at that. We do consider the Mental Health Act in extreme cases, but the biggest frustration I find with family is that we can't just lock people up if they drink too much or they take too many substances. The Mental Health Act does not give us the provision to do that unless those behaviors are very directly linked to an underlying treatable mental illness. And that's just the way the Act functions, I'm afraid. There are medically assisted treatments for alcohol. We recommend drink down in the first instance. Alcohol services don't routinely focus on abstinence, but if people do return to levels of drinking that they like and they can't maintain it, if that persistently happens with risk, we probably would be suggesting that they go down the route of abstinence. We can provide medicated detox in the community with Librium, which is a type of benzodiazepine. In acute situations where people are acutely unwell, they may well have detoxes in at the acute setting. That isn't the most helpful because, again, this is fixing a problem with the physical dependence, but not fixing the life around it. So people in those situations are much more likely to relapse, unless it's been a very long and protracted physical health admission where we can put new things in place. Planned admissions for detox we also offer in detox units. Often if their physical health won't allow a community one or their circumstances aren't good. And we sometimes link that with rehab if people have more extensive psychological problems that they need to deal with, and it's dangerous to return them to the same environment. We also use relapse prevention medications, and these are things like nalmefene, acamprosate, and naltrexone. These are supposed to reduce cravings. And aversive medication, disulfiram. So this is something which people, when they are sober and not drinking, we prescribe. And if they drink on top of it, it gives a really nasty reaction. Theoretically, it can kill people if they drink on top, but more often than not, it gives a rather nasty reaction. So it's just that additional aversive stimulus to stop people using. Very important in detox, which is when people are drinking heavily, it's important to get medical help and not just do it yourself, is people often need access to intravenous vitamins to prevent long-term risks of active acquired brain injuries like Vernicas and Korsakoff's. And if people find that services are reluctant to give repeated detoxes, this is because the process of detox in itself is very dangerous to the brain. And the more you repeat that process, the lower the threshold that you're going to have problems. So it's dangerous. It's a dangerous intervention physically. We wouldn't routinely go and put ourselves under the knife to check if there's anything going wrong, or to do a quick fix to do a pain, sew them up, and then if the pain doesn't go away, open them up again and do it again. Not so it's from a brain point of view, it's probably similar to doing that. But also psychological. If people lapse into the pattern that they can get a quick detox, there's no real incentive to stop the behaviors when the cravings or the thoughts come back again, because they've got a quick fix, and that again will long-term cause damage. Specific treatments for drugs. Opiate substitution therapy is used for heroin. We talk largely about methadone substitute. Now, one myth busting is that these aren't treatments. All we do with these drugs is we substitute somebody's dependence onto a safer compound where their dependence can be managed in a safe way. They're getting safe substances. It'll often be supervised at the chemist, and it's part of engaging with drug treatment. So the real treatment is the psychosocial work. Methadone provides that kind of cushion so that they don't have to think about drugs so much and help them get into a routine of life again. So somebody stable on methadone its job half done, particularly if they're younger. Now, what we do need to do is we need to think about community stabilization. Increasingly in the older people, this is something we go around. So we're providing it to prevent the risks of people dying from lapsing back into drug use. Symptomatic detoxes are available as well, often in the community. And it's a balance that we make in treatment, whether we are aiming to get people in full recovery, so that's off medication on with their lives, versus harm reduction, often with older people who've got long-term risks and are highly likely to relapse, and actually keeping them in service on a reasonable chunk of medication is actually part of their kind of defined recovery. Naltrexone is a medication we use to as a blocker. So if people are off opiates and they're taking naltrexone, we can actually, they don't get an effect of opiate use on top. We also need to think about management of prescribed drugs. GPs are usually pretty skilled at that. And there are, like with alcohol, IP, inpatient detox units and rehabs for people whose problems are more complex. Okay, so the journey doesn't stop with coming off the drugs. It's building up recovery capital. People need ongoing support. Unfortunately, services aren't commissioned to provide this anymore, but it's vital that people have support beyond there. Look at any underlying specific psychological or traumatic events. Keep on top of any mental illnesses and seek accurate help for that. And the reality is it's a relapsing remitting condition. So if you're with somebody who has a problem or you have a problem, don't expect miracles. It'll take time, and hopefully it will work out in the end in a good way. Okay, so I shall leave it there. Thank you very much for listening to me. And I think if I stop sharing the screen, we can do things and take any questions if I haven't overrun my time. Thank you.
Thank you so much, Dr. Sirur. It was an excellent insight into addiction. A couple of questions, if I can read them out, and if you are able to focus on those two and just give your views as well. So the first question is that how can someone be sympathetic with people who are addicted to substance or alcohol? They are effectively self-sabotaging. Why should someone be sympathetic to them?
Well, I think a lot of this is down to our perceptions. Alcohol and drugs are seen as a bad behavior that people need to stop doing. Now, it is a behavior that causes consequences, and it is dangerous to people, and it causes an awful lot of harm, not just to the individual, but the people around them. But again, it's the crucial thing is looking at it as a symptom of something that's underlying. Now, to be honest, if someone is a very selfish git and they spend all their time getting drunk or taking drugs and causing harm to other people and just don't care, maybe that's just how they are. And maybe if you're unfortunate enough to have people like that in your life, then the best thing to do is not have them in your life anymore. However, there will be a reason why they're like that. And what I encourage people to think about is not so much about what they're doing in the here and now, but it's to have a think about how they got to that point. And keep in mind that the person who you are seeing in front of you is an active addiction. That's not them. That's what addiction does to people, and people don't nick off their gran when they're well. You don't go around and take your mum's cancer medication when you're opiate dependent because you don't care and you want to see her in pain. This is the power of addiction. I think people who've had addiction problems will understand, or worked with people will understand that. It's very difficult, I admit, to hear that if you've not experienced that problem yourself. The final thing I think is always important to think about when we're considering it in the context of a symptom rather than a bad behavior is increasingly there is some physiology behind, and we can see what's happening in the brain. What happens in the brain is different for normal people as it is for people who have alcohol problems or drug problems. There are certain deficits in various neurochemicals, most important of which I didn't touch on, is one called dopamine, which manages your reward network. Now, people who have dependence problems will often not have the same responses as normal people for dopamine. Dopamine is your basic well-being chemical, and either as a result of the taking drugs or often as a consequence of longer term problems or physiological problems which may have been inherited, for all we know, their reward system doesn't work properly, and the drugs and maladaptive behaviors creep in, because in order to get that, what our normal, they have to be doing things which get their brain chemicals back to that level. So it isn't just badness, and often it is madness. This is a double-edged sword in terms of stigma. Mental health is badly stigmatized. Substances are even worse stigmatized. If you've got mental health problems and you've got a drug problem, no one wants to know you in normal society, in inverted commas. I think things are changing, which is good, but it's taking away that this isn't a choice. This is something that the initial starting to do it perhaps was a choice. It was a wrong choice, but once you're in that cycle of addiction, it isn't a choice. You're in it, and you're going to stay in it. And the more people are angry and upset and irritated by what you do, the more they're going to be pushing away from the network of people who are most likely to help them get better, and end up with enablers who are just going to make things worse. And what is shocking, and I've talked, people talk to me, how could you work with these 40, 50-year-old men who still use? I'll tell you about these 40 to 50-year-old men who still use. They know exactly what they're using for. They're using because a lot of them were severely, systematically abused as children, were let down by society, have significant mental health related problems, which services don't really appear to have help, and their way of coping with life and not dying is taking a drug. It's the only thing that makes life livable for. So they know that there are treatments out there, but if you've been carrying serial sexual abuse from a partner, from a stepfather, from a mother, from a sibling, and it's been contained, if you've been pimped out by family members, if you've been effectively a child slave, if you're used as a punching bag, that's an awful lot of damage that people have. This isn't the case of all people, I hasten to add, but before we judge people on what they're like now, we always need to have a proper think about what they were, because I bet you 100 quid or a bag of heroin, which is £10, by the way, if the people who are the most difficult to manage people in society and cause us the most anger are often, they're like that because they don't know they've never been exposed to how one does society, because they never had it, and what they got is the worst end of society. And often when they're taken into care rather than getting rescued, they end up getting it worse. And so there are reasons why people end up like that.
Thank you for that. I've got another question. Would you be able to briefly talk about Oxycontin and the misuse of it related to addiction?
I can, yeah. Now, I didn't have time to touch on it because, again, I suppose this is a presentation in its own right. There's two elements of dependence. There's the street dependence, which I deal with as part of my day-to-day work, heroin, which and various other drugs. But there's a whole raft, and I think this is much more problematic, perhaps. I don't know whether that came from the States or because I know in the States it's a significant problem, and other parts of the world, the primary drug problem among certain people is tablet dependence. I think there are various mechanisms which it's not so bad here because we've got a lot more control on what actually is prescribed through our kind of regulatory systems here. But yeah, major problem. In a sense, it's no different to a heroin problem. It's a physical dependence which sets in. Why people take it, it's something that we need to be thinking about. Again, we used to be commissioned to work with people in our service with tablet dependence, and often I've seen these kind of guys in the past, but because of service cuts, we're not able to see them anymore, and they're managed largely with the general practitioner. But often it's having to think about how that, in the same way of how we look at drugs, why did that problem start? What was it about? And why were they taking it in the first place? Often, when I look at these cases in the UK, there's a legitimate reason at the right time to be on a painkiller. They may well have had surgery, they may well have had a broken leg, completely unrelated. But the problem you often find with if it's what we call the iatrogenic problem, so it originally started for a clinical reason but then continued, is there was either underlying psychological or mental health difficulties where the side effect of the painkiller was self-medicating the psychological, or a new trauma came in at the time. Did they lose a partner? Did any of the other problems precipitate it? Were they involved in a life-changing accident? Did they lose limbs? Did it mean they couldn't function in the way they used to, which will come with a depressive component to it? Now, the problem with oxys, they're brilliant painkillers. They're also very, very good anxiolytics. So it comes to a point where you need more to get the anxiolytic effect. You may not care about the pain because the pain may well have resolved by then, but then you're stuck on them. So that's one end. The other end is increasingly now, people that look much more, the younger generation, don't tend to like heroin as much. It's a dirty drug. It comes with all sorts of rubbish, and they don't really like dying. Don't forget, most people who've got a drug problem, they don't want to die. It's a substitute to dying. So we need to think. So if they're so it's fairly common in younger people to use tablets to get the same effects that in the old days people used to use alcohol or heroin for. They'll know what tablets. The internet's a very good resource in a good way and a bad way. In a bad way, it's very easy to get these kind of things. And from a good way, there's also a lot of harm reduction advice on how not to kill yourself when you do those things. So I think that's perhaps a different thing, but in essence, it's the same problem. It's just a different type of opiate addiction. And the big problem we have is there's less ownership. So when we talk about the stages of change, people who we see with heroin or other drug problems or alcohol problems, they've come to a point and they've realized this is bad, it's in their life, they don't want to do it, and they know why they want to stop broadly. When it comes to opioids and an opioid addiction, they may not have insight into it, and they may not want to stop, nor do they want to acknowledge that there was a reason. And also, if it's started by physicians, there's a lack of psychological accountability on the part of the addict to fix it. So if a doctor broke them, they leave the responsibility to the doctor to fix them. But of course, if psychologically you haven't changed in your head, you won't be fixed. And that's whereas with street drugs, if people say that to me, I say, well, I never bought you a bag of heroin. You did that. You've come to me because you've got a problem with it. I'm offering you medication to help with that problem, but I'm only prescribing on these conditions. So the contract, as it were, is set at the start of treatment, whereas oxys and those kind of things cause problems in other ways. Other drugs which people have to worry about are drugs like pregabalin and gabapentinoids, which are relatively new drugs which were marketed as painkillers. So as a rule of thumb, any wonder drug which is good for pain, good for anxiety, which doesn't have side effects of dependence and tolerance, is because they haven't done the research to say that it's going to have problems with dependence and tolerance. So I hope that kind of answers your question.
Thank you for that. Another question I have is, in your professional view, do you think enough is being done to educate or bring all these reasons, teach the young children from a very young age right up to the secondary school level? Do you think enough is being done by the government, by the schools, and part of the curriculum as well?
What, in terms of the harms of drugs and things?
Yes.
Well, I think one thing which we have to think about as a society, again, is that the problem with drugs in particular, and I think with that within our culture, if the majority of the audience is BME, it's that bad behavior thing. Alcohol's bad. You know, you shouldn't be drinking. Drugs are particularly bad. Although interestingly, from what I hear, there's quite a lot of nice stuff in that incense in various temples within our religions. But you know, it's so. But again, it's back to saying something about that. We need to think about why are people getting. So the work at the early stage needs to be preventative. If someone's already got a problem, generally they're at a point, particularly with drugs, because people know that drugs are outside of social norms.
Sorry, can you unmute yourself?
Yeah.
There you go.
So yeah, I mean, if people, so what I was saying is, by the time people are already in that circle, you've lost. If you're an authority figure, you pretty much lost any credibility. They've already moved outside, and they're with a group of people who function outside of society, largely. The key thing is to say, not to go down the just say no and focus on the harms. It's important to know that, but it's to do it in an informative way. The key bit which we need to do in schools is, why do people get like that in the first place? And that's very simple. People get like that in the first place because they're struggling with emotional difficulties, and they're not either resourced or made accessible the tools to stop it getting like that. Most people who drift into problematic substances and drugs, they're self-medicating. They're not. They don't decide I want to do cannabis because it's cool. Lots of people will do that. Lots of people drink because they enjoy it. But that's the difference between recreational takers, who need, where it's much more about making sure they're fully cognizant of the harms. Because if you go down a punitive route as a parent or as a spouse, and they want to do something, they will do it, or they will resent you for stopping you doing something that they want to do. And either way, that's not a good thing. If they're doing it anyway, they will do it secretly. And this is, you know, a lot of things I see in the Asian community in the UK. I've got a lot of friends who, I used to get perhaps a bit of criticism, not from my parents, but from other people in society, because I was actually quite open about my lifestyle. Wasn't particularly dodgy or ropey or anything, but it wasn't the type of lifestyle that they felt a good Asian boy should be doing. You know, mixing with girls or drinking beer and all these kind of nonsense things, even maybe smoking. It's all right for uncle to do it, but not us. And that doesn't work. It drives that thing. You need a relationship with your kids where, if they're having difficulties, they can talk to it. If there's a punitive response, it'll lead to concealment or having to trying to sort out the problem themselves. And if you're not there to do it, and the teachers aren't doing it, they'll find someone who pretends they can do it, or they'll be lucky and they'll find someone good to help. If there's a good, so in terms of what can be done at schools, it's focusing more on how one deals with anxiety, how one talks about things, empowering kids and young adults to learn to talk about things, how one accesses services, what happens in processes, normalizing the fact that, as I was saying, there's a good chunk of people who have suffering psychological trauma, maybe not to the level of intense abuse, but most of us will be carrying some form of trauma associated with our childhood. We may not recognize it as such, but those things impact on our anxiety, stress, coping skills. And if you're unlucky enough to be introduced to a substance at that time when you're vulnerable and it hits the spot, that's when you're going to start having problems.
Thank you for that. I think there's a helpline number as well, Dr. Sirur, which I'm just looking at. There's a Frank Drugs helpline number
There is,
in
yeah.
the UK, and I've got that number, which is 0300 123 6600 for anybody who may feel they may want to contact.
Yeah.
That number.
That's really helpful. And the other thing is, there's if you live in the UK, certainly every area will have a drug and alcohol service. They usually drop in. So if you know of somebody who needs some help, They're usually fairly easy access. You can look them up on the internet, and they've usually got a free phone number. They're self-referral. You don't have to go through GP, and they're very used to dealing with confidentiality. One of the problems that people face with substance misuse is because of the stigma, they feel they're on their own. And one thing which is really beneficial for people who have a problem is to realize they're just quite normal. Things have gone wrong, but they're not exclusive. It's not just them. There are loads of people around, and people are increasingly getting comfortable with being open and honest about the fact that they've got problems. I think it's great what's happened on the Olympics recently. People are saying it's okay not to be okay. Ben Stokes decided he didn't want to go and tour because he's got emotional difficulties and didn't want to be away from his family. Now, in the past, that wouldn't have happened. He'd have got drunk, and there'd be some stupid headline about him getting into a fight or being silly on a pedalo on a beach or something, or being seen in nightclubs when he shouldn't be. So it's allowing people to be vulnerable and not see it, and it's back to parity of esteem. Mental health is just as important as physical. You've seen from the slides, if you're a man in between 20 and 34, your mental health is actually much more likely to kill you than a road traffic accident or getting into a fight or or a cancer or anything like that. This is serious stuff, and until as a society we stop seeing mental illness as weakness, and this is the problem. There's nothing weak about being mentally ill. In fact, as people who have the courage to say forward that they're a lot stronger than most other people. It's about seeing it as an illness, not about a weakness. Just like with addictions, it's not people being bad and not stopping something they know is bad for them. There's a mechanism that's going on in your brain, which means you can't do the blindingly obvious. Now, if you have a problem, let's take depression, for example, or any treatable mental health problem, which can be managed with medication, schizophrenia, bipolar disorder. Is it weak to need a medication to replace chemicals which aren't working properly in your head? Because if you're saying that's weak, I would say anyone who's on a statin to reduce their cholesterol is weak. I'd say anyone who needs to be on insulin dependent, who's insulin dependent, who needs insulin is weak. I'd say anyone who needs thyroid replacement is weak. I'd say anyone who's taking blood pressure tablets to reduce their thingy, because they've made a lifestyle choice. Why should I pay for people eating too many roti? Or not enough roti, probably eating too much ghee.
Yeah,
so
agreed. Do you know, Dr. Sirur, one of the things that I think, and from what I've read, I think it's quite difficult to diagnose mental health. Do people use that as an excuse?
Yeah, well, yes, people who have got problems with addiction will use mental health as an excuse when there isn't one. And again, when we talk about one of the things which we have to walk, and I was talking about walking that fine line between being supportive but not being enabling. All the things I've said about mental health, all the things I've said about people having trauma, in my head doesn't excuse them from behaviors. If someone has a traumatic, I'm sorry, if somebody has a traumatic past and goes off and machetes a load of people, they should go to prison for a very long time. I don't believe in the death penalty, but if you do something bad, you manage it. These guys I'm talking about with trauma, at the end of the day, they know that there is a service out there for them. They're making a choice. For them, they feel their best bet is to maintain their stability on medication to minimize the harms that they're receiving from alcohol or drugs. So that we're talking, but I think one thing we need to be thinking about is drawing the distinction between a mental illness, which is something that's just treatable and we can do something for, and psychological difficulties where people need to take some personal responsibility of knowing that there's stuff out there for them and having the ability to engage with those services, because I can't force someone to psychotherapy themselves better. I can, well, I don't work in that level at that time. I don't work in inpatient psychiatry anymore. But theoretically, if I'm on call and I see someone psychotic, I can legally force them into a treatment unit, a psychiatric unit. And if they don't want to take medication, we can inject it into them until they're better. Then they can make the choice of what they want to do. So, but I think actually, with most things in society, there's this tendency to focus on the small minority. If I were to tell you most of the people who I see aren't benefit scroungers, but their whole purpose of staying in work is coming to services is to maintain their employment, you probably wouldn't believe me. If they want to get stable, because if they're stable, they don't need to take drugs, and then they can access other therapeutic options, or go to college, or make up for the fact that their life was a mess and they want to do something about it. That's the majority of people who take drugs. The majority of people come to see us because they know it's bad, they know it's harmful, they know they're being bad parents, or they know they're being bad spouses, and they want to move on with their life, and this stuff's holding them back. And likewise with mental health, there is often something going on, but if people are using their mental health as an excuse, that's when, from our end, we're very boundaried. We'll say your mental health isn't an addiction problem is an addiction problem. Your underlying mental health or disorder, because I think there's too much pathologizing of normal human experience. I think as a doctor, I focus very much on illness, treatable illness, and looking at people's capacity for other problems. Are the services they need available, and are they choosing a lifestyle choice where if you make a choice, you also accept the consequences? Or is there, or is there a meaningful intervention that can be offered? And if you want to take it, it's there. If you don't, you are responsible. But never shutting the door on people.
Yeah, perfect. Thank you very much. I think there aren't any other questions. Let me just check. No, there aren't any other questions. I think we have come to the end of the presentation. Thank you so much for doing this presentation on addiction. Very, very insightful, and really appreciate your time.
Thank you for inviting me.
Thank you.